us on today's webinar, Unpacking the Results from ReviveHealth's 9th Annual National Payer Survey and athenahealth's 10th Annual PayerView Report. I'm Margaret Pell, Marketing Manager here at ReviveHealth, and I will serve as today's moderator. Before we begin, I have a few housekeeping items. First, today's webinar is being recorded. We will be sending an email with the link to the recording immediately after the webinar concludes. Time permitting, there will be a question and answer session at the end of the webinar. We want to hear from you, so please feel free to submit your questions, comments, and thoughts at any time throughout the webinar by simply typing them into the questions box on the right-hand side of your screen. Please be aware that while we may share your question with the group, we will not include your name or the name of your organization. If you experience any technical difficulties during today's webinar, please refer to the troubleshooting website and toll-free number on the right-hand side of your screen on your control panel. Please use them if you need to. If you are having trouble hearing the audio presentation, the best solution is usually to call that number. Also note that to resolve a problem of slides not advancing automatically, try exiting and re-entering the webinar. At this time, I'd like to introduce our presenters for today's call. With us on the line is Lori Graham, Payer Operations Manager at athenahealth, the foremost provider of cloud-based services for electronic health records, practice management, and care coordination. Brandon Edwards, CEO of ReviveHealth, which is the leading integrated marketing communication firm focused exclusively on health systems, health services, health technology, and healthy living. Also with us today is Dan Prince, President of Catalyst Healthcare Research, a top healthcare market research firm. First up, we'd like to welcome Lori, who will be discussing the key takeaways from athenahealth's 10th Annual PayerView Report. Welcome, Lori.
Thank you, Margaret. I appreciate the opportunity to present PayerView findings with Brandon and Dan to this great audience today. Again, my name is Lori Graham. I'm the manager of Payer Operations at athenahealth, and this team is not only responsible for putting together the PayerView report, but also increasing the impact of this operational insight from the report by working with payers in relationship over the year to achieve business outcomes for our providers. So PayerView is one of the few public resources that provides evidence-based insight on payer performance nationwide, and I'm really excited to present our findings in the 10th year. By way of introduction, next slide. For those of you who might not be familiar with us, athenahealth is a leading provider of cloud-based services, including an award-winning EHR, an integrated practice management system, care coordination, and patient communication platform. Since PayerView's debut, we've grown to almost 4,000 employees in 9 locations and $600 million in revenue. This image is of our headquarters in Watertown, Mass., where I'm speaking from, and where we serve 64,000 providers across the nation and across medical specialties. In the next slide, I want to introduce our tremendous purpose. Every Athena employee believes in these 2 statements with our whole heart. Our mission to be caregivers' most trusted service and help them do well by doing the right thing, and our vision to be the information backbone for our providers to help healthcare work as it should. And PayerView is a big part of realizing this vision and staying true to our mission. The evidence from our analysis is derived directly from our providers' daily experience with payers, and hopefully will highlight areas for industry improvement so that our providers can really focus on delivering care. In the next slide, I mentioned that Athena is a cloud-based service. And that means we can query our network data set in real time, anytime, essentially pop open the hood and see what exactly is causing trouble to establish provider workflows for our providers across the country. It goes without saying that this monitoring and model allows us exceptional access to intervene and resolve escalated issues in real time on behalf of our providers. And in aggregate, the professional claims data set gives us an engine status update, a sort of state of the union of payer performance for ambulatory physicians nationwide, which brings us to our goals and objectives of PayerView. Every year, PayerView is really our chance to pause, take a step from out behind our desks, and provide network insight to the industry so the industry can respond. We hope that PayerView continues to inject transparency to reveal the dynamics that actually create the most inefficiency and cost across the supply chain. We use PayerView to drive our conversation with payers to help them realize performance improvement throughout the year. And we use PayerView to empower our provider network with a comparative tool that can characterize the ease and difficulty of doing business with a given payer, and then help those providers use the insights and take action on this information to make informed business decisions and to hopefully better respond to industry change, like the shift to value-based reimbursement and the transition to ICD-10. In the next slide, I present our sample used for PayerView this year. So PayerView rankings were derived from activity within the athenahealth database. In 2015, the PayerView results are based on 4 quarters of data from the 2014 calendar year. The data includes 145 million charge lines of medical services that were billed by providers across 50 states, and 166 payers are ranked. That is our biggest data set yet, and equal to 7 times the number of providers and 5 times the number of charge lines that was first evaluated in our first installment of PayerView back in 2006. So we're more than excited about the large data set this year. In our next slide, PayerView is an evaluation of payers across 3 performance zones. We're looking at financial, transaction, and administrative performance. And we feel these metrics really reflect our provider experience as measured by operational workflows that are essential to their business. So this is taking into consideration that provider-payer contract negotiations may go smoothly, but at the end of the day, these measures answer questions like, how difficult was it to get paid? Were payers timely? Did their denial codes make sense? Was the payer upfront about what was needed to submit a claim to avoid a denial? And then in the next negotiation, will you want to bring up some of these operational concerns in your conversations? So hopefully these answers can help empower providers to make real data-based application in their decision-making and have an implication for their business strategy. Metrics are weighted to contribute to an overall payer score and ultimate ranking, and these weights were designed to ensure that no one metric contributes disproportionately to the overall score. So speaking of scores, in the next slide, we'll move forward and share our rankings with you. Coming in first place in PayerView 2015 is Health Partners. Health Partners is a small nonprofit plan in Minnesota. Providers have been submitting claims to this payer using the Athena network for years, and Health Partners has been among top payers in 2012 and 2013. Coming in second is Group Health Cooperative, a nonprofit based out of Seattle, Washington. And despite the name is not a traditional cooperative, but has notable leadership and a reputation for doing very well as well. So these are top performers who've pushed into the first rankings of PayerView this year, and we expect to see more of them in the future. Humana remains the only national commercial in the top 10, competing with lean and small market blues that dominate the top 10. This year's payer sample was pretty interesting because there were new entrants to the market where traditional lines between payers and providers have blurred for some integrated health delivery systems. And in the top 10, we see that mix reflected here. So Health Partners, Group Health, and Maryland Physicians Care MCO are all health plans offered within integrated health systems. So this will be an interesting trend to watch as these alignments continue to emerge and whether or not these health plans continue to compete with historically top performers. In the next slide, we'll see Humana compared to its like competitors. So Humana ranks first in overall performance among the national payer category for the 4th year in a row. Humana is quickly followed by Aetna and Cigna in the rankings, and payers who rank closer to the top have dedicated resources to first make efforts to meet the requirements of HIPAA and administrative simplification and regulation like the CAQH core operating rules and other regulations and CMS guidelines. And second, I wanted to pause and explain how these payers actually also go the extra mile towards investing in their performance. They invest in lean operations. They look to consolidate claim processing platforms. They aim to be as transparent as possible with their claim submission and clinical policies, so claims go out the door the first time the right way. Payers who do best are those who are closely monitoring their accuracy and efficiency and clarity of their total electronic transaction volume. And we find that those payers doing incredibly well are not only doing that monitoring, but they're putting resources against non-transaction-based workflows that still need automation. These payers are looking for any way possible to improve performance, to save costs, develop new innovative ways of doing business more efficiently, to improve both the provider and member experience. What you don't see in the rankings, though, is the difference between the first, second, and eighth rank is actually pretty small. So the race to win PayerView is incredibly tight. And on the next slide, I'll share with you an overall PayerView performance in value for this year compared to last year. So on this slide, what we're looking at is the average values for measures in 2014 compared to 2015. And we see that they were not significantly different. In fact, in the highlighted column, you'll see that the difference is less than 1/100% for most metrics. The metric with greatest magnitude of change in a negative direction was the one-day increase in DAR. It took on average 1 day longer to see payment in 2015. And for 166 payers across a network of this size, that is a rather pronounced difference, and no one payer we found was skewing the average. So we were pretty curious about what was driving this increase and found that the delays in most cases weren't things like days in process or claims processing speed at the payer, but actually a constellation of small issues that in aggregate revealed a pretty significant impact on Athena providers. And this is somewhat disappointing because payers had made so much progress here. And so what we found was that this is almost a reversal to a death by a million paper cuts. Providers can't close out claims because they're still needing increased payer transparency around payer denial patterns, enrollment, and credentialing status. And there are cumbersome workflows to be refined, removed, or relaxed entirely so that payers can more easily allow providers to work old AR and access portals more efficiently. So these are some areas where payer-provider alignment has potential to grow. Overall, in the last column, there's quite a bit of green, as you'll see. So 7 metrics out of these 9, saw improvement. And on the next slide, we'll see more observations about market trends in 2014 that had an impact on performance. So every year there's market turbulence, and this slide shows this year's no different. Regulation, competitive factors in the payer landscape can really impact PayerView performance. Of course, we avoided ICD-10 when Congress decided to delay, but this year was no different in that 2014 had unknown risks to payer performance. So what we found was that turbulence like this did actually not degrade the payer performance as expected. Events like the problematic rollout of the healthcare.gov, which were expected to have a negative impact on eligibility accuracy, did not reveal that trend. Similarly, the influx of high deductible plans and the exchanges didn't result in an increase in provider collection burden this year, as many of us might have expected. With so many events like this linked to health reform, we thought we'd take a closer look at just that topic. So on the next slide, we have 2 trends. On the left, you'll see in 2013 and 2014, Medicaid expansion states actually performed better than non-expansion states. For both groups, non-expansion and expansion states improved in 2014, but the Medicaid expansion states performed a little better. Where we might have expected the swell of Medicaid enrollees to erode performance in those states, it didn't, at least from the provider's perspective. On the right, we see a similar trend for Blue Cross Shield plans and commercial payers that offered health plans in the health exchanges. Those who participated in the exchanges actually performed better than carriers that did not offer health plans in the exchanges. So in the table, you'll see that the HIX payers actually pay a little faster at 26.78 days in AR. They deny a little less at 6%, and they have higher benefit reliability at 87%. So overall, what we found was that payers who are participating in ACA implementation appear to be performing better than their comparison group, which is pretty interesting. So with those takeaways, we have our last slide where we have some actionable recommendations for payers going forward. It's never been more important to have concrete recommendations to take action in times of high uncertainty that are related to ICD-10 and value-based reimbursement. And this graphic represents our recommendations for payers that fit into an impact effort scale. In the top right corner, call reduction is categorized as high impact and low effort. The recommendation here is not to shift high-cost calls to a portal, but rather create direct conversations with their provider network and do things like share claim submission and clinical policy changes, explain denial trends, provide clear and efficient enrollment and credentialing workflows, all that can avoid calls. Also wrapped up into this would be providing pre-authorization information, pre-certification information, and referral information to providers so that they know when those things are required before submitting a claim. If you are leveraging a portal, the recommendation here is to provide easy and administrative access so that large health systems and provider services can easily scale the payer portal use. And if you're already ahead of the curve, you've maybe already moved away from portals and are realizing the opportunity for cost savings is really through new types of data exchange. So the recommendation here and in the bottom line is to implement high-impact industry standard transactions like the 275, the CCD, and the 278, or in creating direct connection and API connectivity for even greater impact. So I'll conclude with the fact that as providers are increasingly taking part in risk-sharing models and navigate big changes such as ICD-10, they are needing to find payer partners that have strong core operations and are differentiated on performance and transparency. The financial, administrative, and transaction metrics we use to rank payers provides, we think, a powerful guide for providers as they work to serve patients and get paid more efficiently. And it also offers recommendations where payers can see meaningful operational savings. Finally, improved performance may not still be enough to support provider relationships, given so much tremendous transformation up ahead. And so this is where ReviveHealth can give providers that other piece of information to give a holistic picture of the payer. So I'll thank you for my time to share the PayerView results, and thank you for listening, and I'll pass on to Brandon and Dan and look forward to your questions at the end.
Thank you so much, Lori. Yes, as a reminder, we will have time at the end for a question and answer session. So feel free to type any questions you have for Lori into the box on the right-hand side. Moving along, Brandon and Dan, take it away.
This is Brandon. I just want to introduce this year's payer survey results and our trust index results, and I make a couple quick points before I hand off to Dan to walk us through really a lot of the important nitty-gritty here. The first is I want to really thank athenahealth and Lori for being on today. For those of you who don't know, the Athena's PayerView actually was the inspiration for our payer survey 9 years ago. They had started the survey the year before, and we really saw an opportunity to meet an unmet need in really a qualitative complement on the health system side to what we viewed was really exhaustive, deep quantitative analysis from Athena's database. So what we're really looking at this year is presenting the most complete picture of the payer-provider interface. Trust and the quality of relationships between payers and health system financial professionals who negotiate their contracts, and those professionals negotiate contracts for hospitals, for outpatient facilities, and for physician groups, and also the quality of the administrative and financial performance of payers with physicians and outpatient claims, which we just saw from PayerView. We really believe that this provides a much clearer picture of which payers might be the best partners for providers, which payers providers can trust, and ultimately we're going to be looking for other opportunities to dig into key aspects of those payer-provider relationships in the future as the market continues to change. So let me turn over to Dan Prince, who will start to walk us through really the overall survey findings, methodology, et cetera, and then we'll start to take questions.
Well, as Margaret said at the outset, this survey process has been underway for 9 years. But last year, we collectively made a decision to dramatically shorten the survey and focus very heavily and intently on the issue of trust. Because we were really interested in measuring the degree of trust that health system executives actually have in the health insurance companies that they deal with directly. And for the purposes of our survey, to make it a national survey, we focused in on the ones that are the largest health insurance companies, as you'll see as we move into the results. You might wonder, how did we come up with a trust index? Well, at our end, we did a review of academic literature that really looks at how people define and describe the issue of trust. And we really shake it down to 3 elements, the element of reliability, the honesty, and fairness. And you'll see those reflected in a moment when we get into the actual results. Then by combining the scores on those 3 measures, we're able to derive an overall trust index score for each of the major insurance companies. So as you'll see here in a moment, the scores have not shifted very much year over year. But once again, in my view, they do not paint a very flattering picture of how health system executives view the major payers. So if we look at who participated in our survey process this year, we had about the same number of health system executives this year as we did last year, around 200. And 2/3 of those were executives who are actually in charge of the managed care relationships, with key responsibilities for negotiating the contracts with various health insurance companies. You'll also note from this slide that 1 in 5 were C-level executives, including CEOs and COOs and other senior level administrators. So you could say very definitively that we're getting a high-level view from the provider point of view on how trustworthy the various major payers are. So let's take a look now at which payers were included in the process again this year. And the payers under contract, as you can see from the charts here, merely everybody said Aetna, United, Cigna, and at least one of the Blue Cross plans. Now, it's important to note that when people are rating Blue Cross Blue Shield, we ask them to rate the Blue Cross plan that's in their state, or in the case of health systems, the Blue Cross plan that they do the most business with, the one they do the business most often with. So in the other category, of course, there are many, many other payers, and some of those are regional in nature, like Kaiser, and others could even be smaller. It might be state-level plans. So that's who's represented when people are talking about these payers, and they've got a real base of familiarity as reflected by this slide.
Yeah, and if I could just add one thing to that. Some of you, if this is your first time sitting through this webinar, may be thinking, I really want to know how my Blue Cross plan fared, right? So if you're in a state where Anthem owns your Blue Cross plan, like Georgia, for example, you can look right up there and see how that Blue is ranked. But we would love to be able to tell you this is how Blue Shield of California fared, and this is how Blue Cross of Tennessee fared, and this is how Blue Cross of Texas fared. But unfortunately, we don't have adequate sample size at the individual state level to do that. The only way to accomplish that, and which we have done in some past years, is to have a state-level survey conducted simultaneously with the national, which we've done over the years in Tennessee, Georgia, Massachusetts, and Florida, I think. But that's really the only way to get to the granular level of state-level detail. That Blue Cross really represents an aggregate. So I think in some ways it's fair to it's fair or unfair depending on whether they're a great performer or a terrible performer, that it does get lumped in together, those 37 plans.
Yeah, great observation, Brandon. Well, let's look ahead now to the actual trust measures, starting with the first one, reliability. And here we see people's feelings about the issue of reliability. The way this was structured is that we asked providers who participated in the survey to tell us to what extent do they agree or disagree with the following statement. This organization makes every effort to honor its commitments. You see that reflected right there at the top of the slide. And that's how we chose to define the issue of reliability. Now, the executives who participated in our survey, again, this year used an agreement scale that did not change year over year. And if they said, we strongly agree with that statement as it pertains to Cigna or Anthem or whoever they were rating, we would score that at 100 points. If they said they agree, it would be 75 points. Neither agree nor disagree was scored at the midpoint, which was 50, and so on down to disagree and strongly disagree. So on this slide, Brandon, I think we see a couple of things. One is the average score across the set of payers is only 54, which is just slightly above the halfway mark, suggesting to me at least that in the aggregate, people have a mixed feeling about whether they feel these payers actually honor their commitments. Not a particularly positive picture, in my opinion.
Yeah, I think too is we have to differentiate how we might measure reliability or trust in human interactions than we would in a B2B environment, right? If I were asking this question, or if I were asking my kids this question, do you consider yourself reliable? I wouldn't say, do you make every effort to honor your commitments? I would say, do you honor your commitments, right? It would be very sort of black and white. I mean, in many ways, we're really asking people almost to grade on effort, right? And to grade on that sort of intention as much as the consistency of that behavior. So I would argue that makes the scores appear even worse in a lot of ways, that, the bar of making every effort to honor your commitments is already lower than the bar of actually honoring your commitments every time.
We do see, obviously, a ladder effect here with some plans ranking higher than others, and clearly Cigna and Blue Cross Blue Shield as a brand perform best on this particular measure. At the other end of the bar chart, we see that Anthem and United are scoring worst. I would also point out that while the changes year over year are small and not statistically significant, there is one case on this page that's worth our attention, and that's Anthem. The people rating Anthem actually rated them much lower this year than they did last year, with an 8-point drop on this particular measure.
Yeah, I mean, it's interesting too, right? I think a lot of the talk in the industry was that with new leadership at Anthem and new leadership coming from a provider organization, someone extremely well respected and well liked in the industry, that maybe we were actually going to see more provider-friendly behavior out of Anthem. And at least from this first question, it's not just a change; it's a big change that we saw.
This slide shows the results from our second measure, which is honesty, and you see how the question was asked there at the top of the page. Again, executives were asked to rate each of these players. And on this measure, Cigna and Blue Cross were again judged best in class, if you will, and worst performing were United, and then a new player here, Blue Card. They didn't show up as worst in the last slide, but they do. They're at the bottom of the stack here. Anthem, while scoring relatively low, did not evidence a big drop on this particular attribute. Now, as a group, the aggregate average turned out to be exactly the same as the previous measure at 54.1. And yes, Brandon, we did check the numbers again, just to be sure.
Yeah, another I guess quick point to make here is, if this is your first time, you may be looking at saying, well, why are we rating the Blue Card separately from Blue Cross plans? And now that this is our 9th year, there's a few questions or refinements we made over the years. One of the problems we saw in past years is that people were saying, well, I would rank my own Blue Cross plan one way, but the damn Blue Card program is so hard to work with and so administratively difficult and so opaque, right, to a provider in a particular market that we've separated those out. So, again, for those of you whose first time, you look at it and say, we understand that that's not something that you actually negotiate with, but we want to make clear that ratings of trust and reliability and performance are very different depending on whether it's your home state Blue or it's the Blue Card program.
Now, moving on to the attribute called fairness, and here's the way we asked about fairness. We said, do you see these health insurers actually balancing their interests against those of the providers in a way that seems fair? And as a group, the set of payers here scored much more poorly on this measure than on the previous two. And that's reflected because the overall average dropped from 54 to 47 for the group as a whole. So it suggests that, in the aggregate, our health system executives are more likely to disagree with this statement than they are to agree with it.
Yeah, and I think we've all experienced this anecdotally. Certainly, we've seen a pattern of anecdotal feedback from providers in different markets where it seems to be this notion of balancing interests, right? I mean, I'm always leery of the word fair, right? We have a giant poster in our office in Nashville that says fair is where you get cotton candy, because fair is very much in the eye of the beholder. But I think this notion of balancing interests, not routinely taking advantage. Again, not a super high bar, right? If we're dealing with this on a human relationship standpoint, we would say, don't take advantage of someone else, not don't routinely take advantage of someone else. It's certainly fine to do episodically. So I think it's again one of those really strong indicators that if there is a problem in macro, all of this leaves a lot of room for improvement. But the fairness issue is the sort of the epicenter of the problem between payers and providers in this survey.
So that brings us to the composite picture, where we have given equal weight to each of the three measures we've just reviewed, and we arrived at an arithmetic average then for each of these health insurance companies. And no surprise, given the results we've already looked at, Brandon, Cigna comes out as seen as the most trustworthy payer in this group, while Anthem and United are seen as the least trustworthy.
Yeah, not a good year for Anthem, and I think not a good year for United, and we won't dwell on that because they've hovered in that position for some number of years now. But this is pretty significant year-over-year movement for Anthem. When you look at, coming off a base of 50 to lose, a little more than 3 points on an overall trust rating is pretty significant. And, I think, again, there was so much hope for that. Obviously it's a big organization for new leadership to try to move. Perversely, they performed really well financially, right? Wall Street's in love right now. But they, certainly we have seen over the years the long-term effects of poor relationships with providers, and you got to believe that Anthem's watching that and looking at what their strategy is going to be for the long term.
And Brandon, isn't this one of the places where our results kind of dovetail with the PayerView results, and that Anthem and United also came out lower down on their rankings, if I remember right?
Yeah, I think there are a few real areas of congruency, and I think that's one of them, right? I mean, there are some areas of separation, I think, largely by the fact that ours is purely national, whereas Athena is able to look in individual markets given the sheer size of the data set. But clearly there is important congruency here where the worst ranked payers for trust by the people who negotiate contracts are the worst ranked payers for the performance against contracts when it relates to administrative efficiency, to payment, to physicians and outpatient providers. So yeah, I think there is clearly a pattern there. You don't have to stare at it too hard to see the connections.
So if you're not a health system executive yourself, perhaps you're wondering what's behind these trust index scores that we just saw. Put another way, why are some insurers seen as more trustworthy than others? And we've started that conversation here. But we actually asked a question in our survey process again this year to try to dig into that in a little more detail. And this slide provides a strong hint as to the answer. We asked each respondent in our survey to assume that they had a total of 100 points, and they could distribute those 100 points across these 5 factors based on how important that factor is in explaining the overall relationship that they have with these various payers. And a respondent could assign 100 points to one factor if they wanted to, or give 20 points to each of the 5 factors, or use any other weighting that they chose as long as the total points together added up to 100. And what we see in the results shown here is that the most important factor in the relationship with a payer is the fact that payment rates really rise to the top. 30% of the total weight essentially was given to that issue. And of course, that's, I think, what we would expect, having looked at these results over a number of years and listened to the commentary of those of you who are on the call and the comments that you provide to us. But look at the next factor. It's actually not about rates or AR days. It's about negotiating in good faith. And I think that speaks to what you were commenting on earlier, Brandon.
Yeah, we've had this question a fair amount in past years. More from people who are covering the industry from a media standpoint, or even to a certain extent from an analyst standpoint, say, well, doesn't the survey just show that hospitals love payers who pay them the highest rates? And say, actually, I don't think that's what the survey shows. Rates are important, there's no question. But in past years, we've had plenty of times where the top-ranked payer from a rate standpoint was the lowest-ranked payer from a trust standpoint and a relationship standpoint. I think what this really shows us is that clearly rates are important, but it is the totality of the relationship that's important. It's, am I being treated fairly, and am I negotiating in good faith with a real partner? Am I getting paid the way I'm promised? Am I getting paid in a timely fashion? Right? It really does go more toward the combination of factors that build up to the relationship, and not just straight rate. I mean, I think we have plenty of clients who tell us, look, the rates are one thing. Actually, getting that money is something entirely different.
And that's reflected in the other factors that you see scoring here on this page as well. Getting paid on time, minimizing the hassles and delays associated with getting a claim paid, and then, of course, the front-end process, too, is important, authorizations and eligibility.
I do think, too, that this kind of comes to the heart of that. We talked earlier about what the epicenter is of the crossover between PayerView and the payer survey. And that really comes to the more we deal with these sort of unknown, unproven contractual models, risk-based models, value-based models, we're going to touch on this, I think, in the next slide, is that the totality of the relationship becomes so much more important, right? In a fee-for-service environment, yes, you worry about rate, and yes, you worry about timeliness, But when you get into risk and you get into value-based payment, there are so many more unknowns, not just your performance against it, but how is payment really going to turn out, and how are gains going to be shared, and what's the accuracy of data, and all sorts of things that really aren't about rate. And I think that that's really where this is so important, is providers have to make choices about who to partner with and who they can trust and who they're going to have a good relationship with and who's going to pay them accurately, fairly, and timely is going to go a lot to their choices in those partnership decisions.
Well, there's been a lot of buzz in the trade press and certainly at the healthcare conferences that I've been to about the whole shift from volume-based to value-based payments. So we asked the question about that. And the question we asked here is, how far along are you on this trajectory? And essentially, what we see from the results is that for the calendar year 2015, our respondents in the aggregate expect that around 80% of their total payments will come from conventional volume-based arrangements. And only around 20% are coming in today from value-based payments.
Yeah, I think it's interesting. Most of the trade data, industry data we've seen is more like a third. I think probably some of the reason our percentage is lower is that our organizations tend to be a little larger and they can afford a little longer glide path toward that. They may not be muscled into arrangements that they don't want to have, or a little more reluctant to take enterprise risk on big risk-based arrangements. I think the other two is just how we ask the question, right? We ask what you expect this year.
Yes.
There's clearly a glide path toward a higher percentage of that revenue being tied to value, but it's not nearly as swift, I think, as maybe we'd be led to believe. We may see a big jump in 2016, and maybe if we'd ask the question about what's 2016, 2017 going to look like, we'd see some different numbers. But it's clearly a little lower than what's been more widely reported.
Well, certainly the Secretary of Health and Human Services is expecting a bigger number within just a few years, at least for the Medicare payment piece.
Yes, yes.
So what about this whole transition? What initiatives are provider organizations actually pursuing? And we asked that question, and you see the results displayed on the PayNet now. We see that the most popular is the insurance-sponsored pay-for-quality programs at 77%. Now, government-sponsored pay-for-quality programs, not far behind, 64%. About two-thirds of respondents are saying they're involved in one of those kind of programs. And the same number, approximately, are reported into ACO-type arrangements.
I think there's a couple interesting things on here. One is that there's actually about a quarter of hospitals that aren't involved in insurance-based P4P programs. I found that sort of fascinating. I would have assumed by now, pretty much everybody's in at least one. But you've got a quarter of hospitals who don't have, they're not in QHIP or one of the P4P programs. I think the other thing that sort of jumped out to me was that the ACO or risk-sharing arrangement at only two-thirds sort of surprised me, right? We didn't ask literally, are you in a CMS-qualified ACO? It was pretty broad, right?
Yeah.
And two-thirds is meaningful, don't get me wrong, but you could have a single ACO pilot with 5,000 lives and qualify for an answer to this question, and you've still got fully a third of health systems who say they don't have any of that.
Yeah.
That surprised me a little bit. Those were probably two things that kind of jumped out.
The thing about taking risk on payment for employees is consistent with the data that we found last year. If anything, that trend has continued and is building momentum.
Mm-hmm. I laughed when we first started fielding this. I thought, well, actually, we're all taking risk on claims from our employees because we provide insurance, right? And we pay for their health care.
Yeah.
But you're right. I mean, I think that notion of our health system employees and their dependents kind of a laboratory for managing risk, it has continued to creep up every year.
Yeah. So finally, we asked an open-ended question, and we asked people to tell us what they see as the single biggest risk to their organization as they look out over a 2 to 3 year time horizon. Now, we expected to hear, of course, transition of the volume to value, but it's not the runaway winner in this particular question. We see that uncertainty is a really big issue, and it really plays into, I think, two of those scores there. Government-based programs and the kind of uncertainty that comes with states like Florida and Texas still not wanting to expand Medicaid. It comes with the uncertainty even around ACA and whether it's going to be upheld by the Supreme Court. and then a lot of other legislative and regulatory changes that are filtering through CMS. So that clearly is on the minds of many of our respondents. Equally important, I think, are payment challenges from the commercial payers, and I think that's reflected in that 14%. And some of them are definitely concerned about a downward slope in rates as the payers come to the table and say, well, you know, in the exchange products, we only want to pay you X percentage of what we might have paid you under a traditional commercial plan. So they're telling us in this survey, I think, Brandon, that that's still something that's keeping them awake at night.
Yeah, I think there are a couple interesting data points here. One, I actually thought narrow networks would be a bigger jump, and I think the difference between what we think and what we know, I think, you know, what I think here is that it's not that narrow networks aren't important, is that it has already impacted. It has already shaken out the market, and that many providers believe that they're in the networks they're going to be in, or they're out of the networks they're going to be out of. The other is that, you know, that transition from volume to value is interesting, right? Of the 81% who didn't list that, I wonder what percentage of them feel really confident about their ability to tackle it, and what percentage are just hoping they can retire before they have to. That, you know, it is tough, and it is a tough challenge for people in this business to manage their way through.
And I think it was in the interest of trying to keep our survey shorter this year that we didn't go into any more depth around that issue. But it is a fascinating question.
I know you do the Lord's work trying to simplify what starts out as about 100 questions we'd like the answer to in this process. So what I think we're going to do then is call an end to the presentation portion of this and shift over into Q&A. And Margaret's going to go ahead and introduce that for us.
Yeah, thank you, Lori, Brandon, and Dan. As Brandon mentioned, we are now going to move into our questions for the presenters. We already received some great questions, and so if you'd like to join the discussion and submit a question, simply type it into the box on the right-hand side of your screen. All right, the first question is for Brandon and Dan. If payers are doing a better job in terms of denial rate and AR time, why would the trust values decrease compared to last year?
Yeah, it's a great question. Again, I'll tell you what we think as opposed to what we know, right? Because our survey doesn't answer what we know about that. I think that, you know, number one, you have to differentiate between the performance in PayerView as it relates to physician payment, outpatient payment, and what health systems executives are experiencing on the rest of their payment universe, right? So as it relates to hospital claims, as it relates to, you know, frankly, a lot of high-dollar claims, whether it's ED or surgical or whatever it is. The other is that I would argue that, you know, while payment timeliness and accuracy and low denial rates are a part of trust, they are not the entirety of it, right? If you could have a low denial rate and timely payment and still pay at a rate inaccurate to what was negotiated in the contract. There are a lot of factors that could go into that. But, you know, I also think that you've got to look out and say that there are payers who did very well in PayerView who also did very well in the trust survey. So, you know, there are some congruencies, but clearly the recipe includes more than just those administrative or quantitative factors.
Great. And our next question is for Lori. What is it about having an exchange plan that makes a health plan perform better? Or is it that the exchange plans are only offered by the better performing payers?
Thanks, Margaret. So great question. So what we found in our data was part of what we reported out on this slide, which is essentially that our takeaway was health reform participating payers performed better than those who didn't participate, and those HIX plans were doing better than non-HIX. And so when we looked back in years prior, still that group of HIX plans were performing better than non-HIX. So that kind of tells us two things. It tells us that they were already performing better, that they had already invested in the claims processing streamlining and in some of the efforts that it takes to ensure accurate and efficient claims processing, but they also have improved with the bolus of new enrollees in the exchanges. So not only were they prepared, but they were able to navigate this additional membership. So one thing to think about too, though, is that the group performance by comparison was really tight. So one thing that HIX payers would need to focus on to continue that lead and continue to do well is to monitor their DAR in particular for those constellation of issues that we had talked about, and ensure that their eligibility is remaining accurate and competitive. Because, of course, we understand from state and federal exchanges that eligibility was a major concern for membership. Eligibility in the provider realm will continue to seek accuracy. So providers will need to know that those patients are not only eligible for coverage, but that they've paid their premium and that they're receiving a subsidy or not. And then for the non-HIX plans, they really need to focus on benefit reliability like the other commercial plans in order to continue to compete with the HIX group. So those are our major takeaways for that group of plans.
No, we've got another question on this end. I want to address something really quick that's been popping up in a number of questions. Yes, you will receive copies of the slide, and recording of the webinar will be available immediately after this, and can be shared. You're more than welcome to do that. There was a question about why we don't test managed Medicaid that I just want to mention really quickly. This survey started, Athena's PayerView started 10 years ago. Revive's payer survey started 9 years ago, and we introduced the Trust Index, I think, 2 years ago. The reason that we haven't tested managed Medicaid is a couple things. One, this really started as a survey focused on commercial, and we wanted to make sure that we were really focused on the area where the relationship was the most negotiated, right, as opposed to where things were 9 years ago with Medicaid and, frankly, even at that point, more Medicare. The other is that the more payers we enter and the broader the number of relationships, the longer the survey is. And so part of it's just trying to be crisp and be respectful of people's time. The third, and I mean this only partially sarcastically, is we didn't want to spend a whole lot of time testing relationships that you lose a bunch of money on, right? That, we're focusing on commercial and to a lesser extent Medicare Advantage as opposed to pure play managed Medicaid, which is just a question of how much you're going to lose as opposed to what your margin is going to be on that business. We've been a little bit hesitant about that. So Dan, you wanted to pull up a question here that we could get into?
Well, someone was asking what they think the role of patient experience is in this whole picture. Does that affect the ratings? Does that affect the view of the providers as they critique these payer organizations? And do you have any sense of that, Brandon?
Interesting. I mean, one, we can't answer it in the survey, right? So let's be fair. That's more a question of, I guess, what our judgment is or what our experience is. Is there whoever asked that question? Is there a particular payer that you're interested in, or are you looking at it more broadly? And maybe while we're giving you a chance to clarify on the questioner end. There's another one that we can pull up. We're also going to put up a poll in a couple minutes, just so you all know. That'll give us a chance, give you all a chance to offer some responses to that. Margaret, you want to explain how that will work, and we can put that up maybe in a minute or two?
Absolutely. So once we launch the poll, we'll give you guys a couple of seconds to answer it, and we'll see those results in real time.
There we go.
Cool.
So there was also a question up about membership churn, correlating membership churn with trust and fairness ratings. Fascinating question, right? So obviously you can't answer that question from one data set. You'd have to look at our survey, and you would have to look at the survey or at national and state level membership data. I will mention something anecdotally from that. So one, I will tell you. Do we believe, and do I think most people on this call believe, that provider network stability and the reliability of provider directories and the satisfaction of providers with different payer partners, does that matter for membership? And I would argue that it is clearly a factor, right? Price of insurance, accessibility of care, et cetera, are clearly big factors. But I'll mention this as just an anecdotal thing. United, has struggled in this survey in past years. United's lost a little more than 1 million commercial lives in the last couple of years. They have offset that with substantial gains in Medicare Advantage and managed Medicaid. And to be fair to United, have fared very well, for example, in employer ratings of health plans. Not so much in consumer ratings, and certainly not so much in provider ratings. But clearly there is a more balanced picture to this, I don't think there's any question that it is a factor in membership churn and a factor in membership loss. How significant is that? Time is going to tell. But you can plot some correlation. That's maybe different from causation.
Well, actually, we did a question last year that got at this.
Yep.
And we asked, in the view of the people that took our survey, if they were answering for the consumers in their market, what plan or brand would they put at the top of the list as an easy plan or a good plan to do business with as a consumer versus the B2B picture. And the answers I recall it coming back was the Blue Cross brand was the one that they felt consumers trusted the most and respected the most. And United fell to the other end of the spectrum.
Yeah. It looks like there's maybe a question about for Athena on Humana as the third-ranked plan. I think the question here says, regarding Humana as the third-ranked plan, did Athena differentiate between the commercial and Medicare Advantage sectors of Humana business? Lori, is that a question that you all could answer?
Yeah, we can answer that. We're actually evaluating the payer based on all business lines. So claims submitted through AthenaNet by our providers for Medicare Advantage patients, for commercial lines of business, all lines of business. So it's all rolled up into Humana's total performance.
All right, Brandon, here's one that's come in. Maybe you could address this first, and then if Lori has a perspective, it would be great to hear hers too. Anecdotally, what's the main complaint you've been hearing providers that has an impact on the trust?
Yeah, I mean, I think if we cut across all payers, that we're not talking specific to any one, I think that the biggest issue that's affecting trust is what rates are negotiated at the table and what yield against that contract ultimately is realized. Meaning, how does language ultimately affect rate? And where those issues are is very different payer to payer, right? The kinds of anecdotal complaints or issues that we hear with United's template contract, for example, are very different from maybe some of the language issues that we see with Blues plans or with Anthem's plans. I mean, still in many states, large dominant Blues maintain unilateral right to amend contracts. I mean, I'm still I'm utterly fascinated by that, right? Like, I don't know how you have a contract that one side can change unilaterally. That doesn't sound like a contract. That sounds like at best sort of a temporary arrangement. But I think that's number one. Number two that we hear that I would say is a close second is the integrity of networks, meaning how networks are narrowed, how those decisions are made, when people are notified or not notified or invited or not invited, I think has had a big impact on trust between payers and providers the last few years. And
some of that's ended up in the courts.
That's right. And I think that providers are nervous about it, and when you don't control something or even maybe have even input in it and find yourself on the outside looking in, that can have a long-term effect on trust in a relationship.
Margaret, are we ready to try the poll?
Yep.
Here we go.
Yeah, so we've got a poll coming up right now. I want to ask you, given what the ratings look like this year, would you do a value-based care arrangement with real upside and downside risk with United? So we want to really get to how trust will translate into your willingness to actually do a contract like that. And there are 5 options here, so because we only have 5 options in a GoToMeeting poll, we could probably have 20 options up there if we really wanted to. We've got about 1/3 of the votes coming in after about 40 seconds, so that percentage is climbing up, and we'll give it a second here for folks to have a chance. While we're doing that, there was a question, another methodology question that popped up. Can you please clarify who was surveyed as part of the trust index measurement? That the overall methodology and the survey respondents are included in the slides that you'll get as a follow-up to this webinar. We'll tell you that they are the health system executives self-identified as the main point of contact for relationships with payers, either the people who negotiate contracts or the people who negotiate and administer contracts. About 1 in 5, Dan, is that right, are CEO, CFO, or COO, and the balance are VP Managed Care, SVP Payer Relations, those sorts of titles that pop up. So about 2/3 of folks who have weighed in on the voting, and kind of interesting early returns. We've got about 44% who say they would not do a value-based care agreement with United with real upside and downside risk. 18% say no under no circumstances, and 26% say no unless it would force us out of network, which I guess is sort of like saying I would do one if it were in the middle of a liquor store holdup. We've got about 1/4 who are neutral or unsure. I admire your neutrality in the midst of this. And then only 31% say yes, they would. 2% say yes without hesitation. 28% now say yes, but only as part of broader contract negotiations. But you've got, 44 no to 30 yes. So about a 1.5 to 1 no to yes. I think it does give us some sense of how trust overall affects willingness to enter into risk-based or value-based arrangements. And I would just say I think that's where this matters, right? This is all interesting and kind of directional for us, but it obviously can have a very real business impact as well. So I think we've got 4 minutes left, maybe time for one more question. And let's take a quick scan through what's on there. There is a question that came in: is what can be done to salvage trust between providers and payers? Who's responsible, and how can it be changed? Probably a much bigger webinar with a lot more prescriptive follow through. But I do think on some level that trust issues are natural in extremely complex business relationships, right? That we're in a highly regulated space. There are a lot of moving parts. For those of you who have not had the joy of holding an actual health system payer contract in your hands, the 12 to 18 inches of paper in 4 binders, if it doesn't make you a little mistrustful, then you're a better soul than I am. But I think that some of this does go down to corporate culture as well, right? That organizations, health systems and payers, have to decide what they're about, and they have to decide who to prioritize, and they have to decide what their organizational values are and how they're going to affect their business partners and their customers and all the groups they deal with. And I think that you have to look at, over a period of time, the impact that culture has on these kinds of ratings, right? That a certain corporate culture is going to hire and retain certain kinds of people who have values that are consistent with that. And I think some of it is about people changing, and some of it's about very deliberate decisions at that corporate level. For those of you who are seeing only part of the screen, don't worry, there isn't anything else to see. Once we move off of the poll, GoToWebinar automatically distorts the screen for us. That's why we did the poll last. You mean they won't see our pictures anymore, right. Brandon? Consider yourself lucky, right? That's what you're left with at this point. So I think we're pretty much at the end of our time. Margaret, you want to close us out?
Yes. I'd like to thank all of our presenters, Lori, Brandon, and Dan. And I'd especially like to thank all of you for joining us today on the webinar and for your great questions. As a reminder, we'll be sending out to all of today's participants a link to the webinar presentation and audio file via email. Thank you all again, and have a great day.